Hi, everyone. My name is Mac McCullough. I'm the Deputy Director of the Safety Net Advancement Center at ASU. I'd like to be the first to welcome you to the initial kickoff session of the Network Structure, Governance, and Operations Virtual Learning Collaborative. First and foremost, I'd like to congratulate all of you for being selected for this learning collaborative. We're delighted that you were able to join us, and we're very pleased that so many of you are interested in participating. We received a really great number of applications and are really impressed and excited with the work that you're doing. I'm just going to be kicking it off here, and then I'll throw it right over to your host for today, Starling Advisors. Just a few quick technical notes. As you notice, the webinar is going to be conducted through Adobe Connect, and then we'll be dialing in via telephone. Hopefully this makes it actually easier.
This meeting is now being recorded.
Hopefully this will make it easier, a little bit easier for us to avoid the technical glitches that sometimes pop up during webinars. So if you have any technical problems, please do email or touch with either me or Kaylee or any one of the hosts and presenters. Otherwise, you'll be introducing yourselves and your project teams today, so I won't spend any more time here. And I'd like to introduce you to Amanda Stangus, Andrew Principe, and Samantha Jones. They will be your tour guides on this 6-session virtual learning collaborative. They are part of Starling Advisors, and they are one of, if not the nation's leading group looking at network structure and governance and operations. So without any further ado, Andy, Amanda, and Sam, please take it away.
Sure. Thank you, Mac. This is Sam Jones from Starling Advisors. And just one more technical note. I think most of you are in control of your speakers. So if you could either mute your phone line or mute your microphone on depending on how you've joined Adobe Connect, we love participation during Q&A, and we're going to have you all introduce yourself. But for now, just to prevent a little background noise, if you could mute yourself so that we don't project going forward. And with that, we'll get started. So nice to meet you all. We're each going to introduce ourselves. Andy, do you want to start? Say hi to the group, and then we can go through.
Yeah, good morning. My name is Andrew Principe, and we're very happy to be a part of this initiative. I hope you'll find that, we've spent a fair amount of time working with safety net groups around the country on this very topic. So we're excited to get to know you all, and welcome.
Good morning, everyone, or I guess afternoon, depending on where you're sitting. I'm in Northern California, so it's still morning for me here. My name is Amanda Stangus. I'm the Executive VP here at Starling, and like Andy and Samantha, I'm just delighted to be part of these conversations with you guys and looking forward to really facilitating what we hope will be a rich conversation around how safety net providers across the country are responding to some of the reform challenges placed in front of them by really looking for new and innovative ways of working together. And that's really what the structure and the focus of this particular learning collaborative is. And we're as interested in learning from all of you as we are in sharing some of our background and experience. So thank you and welcome.
And I'm Sam Jones with Starling, and I just echo my colleagues' welcome to this group, and we're excited to get started. We're going to tell you a little bit about ourselves just quickly. Starling Advisors is a national consulting firm. We work with safety net, primarily with safety net providers, and we specialize in health reform and changing reimbursement and value-based payments. We work with a lot of community health centers, safety net provider networks, primary care associations across the country, really. We're excited for you to get to know us, and we're excited to get to know you. So we actually asked you, and you're very tolerant to have done this, to send us some information about your organization. So the first half of this initial session is going to be hearing from the participants who are part of your cohort here as part of this first virtual learning collaborative. So we asked you to send us some information and some slides sort of share your organizational history. So I'm going to go through them, and I'll just call out the name of the organization and ask if anyone is on the line. And then if you're able to speak up, I can run through your slides for you, and you can introduce yourself to the group. I think we're aiming for about 5 minutes per organization, and you can share whatever you have included on your slides or whatever else is relevant. So I think first we have Cincy Smiles Foundation. Is anyone from Cincy Smiles Foundation on the line?
Yes.
Perfect. You can just guide me through your slides. I'll click through for you. Thank you so much.
So Cincy Smiles Foundation, we were founded in 1909, and we basically are a dental health, oral health agency, and we address prevention, oral health education, and dental treatment of underserved groups in the community. Our mission is to ensure that we are providing access to oral health education, disease prevention, treatment services, especially to those who are at risk. We have several different programs, one of which is a dental center that's located in an underserved area in Cincinnati. We also have portable team programs and school-based health programs. So we function to kind of serve a lot of the community that we live in.
Go ahead.
I'm sorry, go ahead.
Nope, I'm going to tell you to go ahead, sorry.
Oh, that's okay. So we have a board of directors, and Susan Lapola is our board chair, and then Sonia Dreves is our executive director, Sandra Borneman is our director of programs, and Robert Merkel serves as our chair dentist. Here are just a couple pictures of our people in our facilities. So the 3 pictures on the left are of our McKean Dental Center, and you can see our assistants and doctors serving patients that come into the dental center. The 2 pictures on the right are of one of them is a volunteer dentist, and the other one is our school-based program. We actually have a mobile van that goes to schools, and so the picture on the bottom right is of a dentist and assistant serving some kids. Our health reform experience, a lot of our patients that come into our dental center have Medicaid, so we've seen a high number of patients with Medicaid, a greater number of people scheduling. So we are serving a larger population, but we have discovered that the reimbursement rates are extremely low. We do have quite a large no-show rate, but at the end of the day, we're serving a great number of people, so there really is no con to that. Our learning goals for this collaborative will be we want to develop some strategies to help improve our dental center communication, clinical care, teamwork. We want to make sure that we're helping everyone that we can, improving operations and clinical integration through all of our programs so that they function better as one entity, and also improving patient data collection and billing processes.
All right, thank you so much. So next up, we have the Finger Lakes IPA. I'm going to pull up your slides. Is anyone from the Finger Lakes IPA on the line?
Yes, you have Jason Dunn and Janice Harbin.
Hi, Janice. Hi, Jason. Thank you so much.
You're welcome. Sorry for the late delivery of the slides. By way of brief background, New York State entered Medicaid redesign 5 years ago and has developed a program which is the Delivery System Reform Incentive Payment Program. Its purpose between now and we're actually entering year 2 of the program itself is that within the next 3 years to move from a fee-for-service payment system to a system in which there is a 10% per patient per month payment, and 90% of the payment is based on outcomes. The program is intended to fund itself through reduction in avoidable emergency room visits and avoidable readmissions to the hospital. The state has been divided into regions. The Finger Lakes region, a group called the Performing Provider System, which is how the state is designating an integrated delivery system, The Finger Lakes Performing Provider System stretches from Lake Ontario to the Pennsylvania border and encompasses 13 counties. The Finger Lakes Performing Provider System is brought together by the two major hospital systems in the area, and it is called FLIPS. As the FQHCs in the area and some community-based organizations began looking at where New York State is taking the program, and the fact that at the end of the district period, the state will be writing checks to the managed care organizations in the state, who in turn will be responsible for distributing the funds throughout the PPSs in which they participate. We became concerned that the role of independent safety net organizations could be significantly diminished and that financial sources to pay for services could end up being reduced. So under the leadership of some of our colleagues, we're in the process of forming the Finger Lakes IPA. Hence, as a result, we don't yet have a mission statement. I think, though, we can say with some certainty that the mission overall of the IPA will be much as it is for each of the FQHCs, to deliver the highest quality primary care possible to all who may show up at our doors without regard to ability to pay, but always in a culturally sensitive, linguistically sensitive manner. So the purpose of the organization really is to maintain the independent viability of the safety nets, share our clinical experience, and look at integrating, even if it means virtually, some of the community-based organization services like chemical dependency, and position ourselves to be in an effective place to be able to negotiate contracts with the managed care organizations when that actually comes to be. So I'm sorry, long term on the first slide there. These are the folks that will be participating in the process. As you can see, it's essentially the top leadership of each of the FQHCs that are participating in the formation of FLIPA. And the next slide will show you a little bit about each. Upper left-hand corner, Oak Orchard Health is primarily serving a migrant population in rural areas. Below that, Regional Primary Care Network has a mix of urban and rural centers pretty much throughout the state. Bottom right, Finger Lakes Community Health serves primarily a migrant population in some of the poorest counties in New York State. And Jordan Health, which is who Dr. Harbin and I are affiliated with, we're predominantly urban. We have 10 locations, 9 in Rochester, New York, and 1 in Canandaigua. The group as a whole has approximately 30 separate clinics throughout the areas that are served. So next slide, please. So we're a little bit further along with Medicare redesign and healthcare reform. Certainly the ACA helped us. We did see our Medicaid population increase, as did others in the area. New York was a very early adopter of expanded Medicaid. But as we've gotten into the district process, we're finding that we've always collaborated well as a community, particularly among the FQHCs. That's only gotten better. We're looking for a much better data exchange and an increased focus on patient outcomes as a group. But we have some real concerns on the downside. The managed care organizations, who frankly are not our friends, are taking a much larger role inside of Medicaid. The hospital systems are increasingly competing with us. One just opened up a primary care center between 3 of the FQHCs, like smack in the middle of our 3 locations. They're also starting to woo away our primary care workforce. We're losing clinicians, we're losing behavioral health staff to the hospital systems, and frankly, it's because there are not enough folks, as I'm sure everyone on the phone would agree, in the workforce today to meet demand. So those are the challenges that we're facing right now. Our goals, we went about this, we want to learn more about IPA management. How do we set up a governance structure? Who should be members? We're new at the idea of financial and risk management across multiple organizations. And then we need to hone our skills in contract negotiations. So as we sit down with the MCOs toward the end of the DSRIP development period, we don't trip over any laws, and we are effective in our negotiations.
Okay, thank
Like
you,
that
Jason.
brings close to flip off.
All right, thank you, Jason. So next we have Crescent Care. Is anyone from Crescent Care on the line?
Yes, hi, this is Alice. Hi, excited to be part of this group. We're an AIDS service organization that made the leap to becoming a federal qualified health center about 2 years ago. And we've grown tremendously over the last several years. Expanded mission, changed our name. We now have 3 clinic locations under scope. We've expanded into dental and OBGYN. We're serving about 5,000 patients. And let's see what else. We're working with our LPCA on an ACO application right now. Are there other slides you want to flip? Yeah.
Yep.
So these are the folks that we've asked to participate. I'm Alice. I'm the Chief Legal Officer, and I've got Lucy, Corse, and Seema. I know are on the call right now. I think Nelson is out of the office today. And these are just some pictures on of our site locations. Here in Louisiana, we're about to go through Medicaid expansion. It's very exciting. The state has, with our new governor, has done a tremendous push over the last several months to move folks that are on our Medicaid waiver programs onto regular Medicaid, and also moving folks that are eligible under food stamps onto Medicaid programs. So we've been working on enrollment and doing a lot of patient outreach with that. Just some of the, mention some of the pros, but there's a lot of uncertainty with Medicaid expansion and our rapid growth, and those are just challenges that we're still working through. I just wanted to give an opportunity. Lucy or Seema, do you want to add anything else that I've missed?
No, thanks, Alice. It sounds like that's a pretty good overview.
Nothing.
Okay. Right. Thanks to all of you. Next we have Kearney County Hospital. Is anyone on the line from Kearney County?
Yeah, it's Benjamin Anderson. I'm the CEO of Kearney County Hospital, and Kendall Carswell is our Pioneer Care Advocacy Team Director. We're both here to introduce KCH to folks.
Cool. Would you just like to share a little bit about your organization and what you hope to get out of this virtual learning collaborative?
Sure. Our organization, so we're a full spectrum rural health care facility that serves it's a county-owned facility that serves about 12 counties in southwest Kansas. We are known for end-of-life services. We have an attached aging services complex that's part of our facility. And then we're also known for OB. So we deliver 200 to 250 babies a year, and those moms drive for about 120 miles to deliver a baby here. So we're a key access point for beginning and end-of-life care. Our hospital has secured significant primary care infrastructure in the last 3 years by intentionally recruiting medical missionary-minded doctors to work here. We offer all of our physicians 10 weeks of paid time off to serve in developing countries because we happen to serve about 30 countries in our service area. We have refugees from all over the world who come here and work in the beef packing plants and the feedlots. And so our physicians choose to spend their vacation time serving in the very places that many of our newest immigrant neighbors are from. So as you might imagine, patients from 30 countries may present some formidable challenges with regard to primary care and public health. And so our providers are really wired to serve them. Our mission is to provide quality, compassionate healthcare services for our community and enrich the lives of our family, friends, and neighbors. It's our expectation that everybody in our organization knows that and lives by it. If you want to go to the next slide.
I don't know if we got slides from you, so you're just you can just sort of talk us through it.
Hey, you just switched to one that looked like it was it. What?
They got our slides.
No, maybe not. Okay. Kendall thought he had sent them. I apologize. to our town of 2,200 people last fall. And by this fall, all 6 of those new providers, totaling 13 medical providers, will be at capacity, and we'll begin to have to turn away new patients starting this fall. We have the only ENT service from Wichita, Kansas to Pueblo, Colorado, and the only access to high-risk pregnancy services in that same space. So as we've grown and our primary care space has tripled over the last 10 years, our footprint has tripled, we've not grown in the right ways. Our clinic utilization has gone up 21%, our ED utilization has gone up 45%, and our hospital days have gone up 126%. And that is removing OB, that's non-OB acute and swing bed days. So we're not growing in the right ways. And so about a year ago, we received an HRSA grant for about $300,000 to help build some value-based infrastructure to get people to the right place at the right care at the right place at the right time. And our participating leaders are Kendall and I, as I mentioned. Our facilities are in relatively good shape. We are adding modular facilities to try to accommodate the growth, but overall our hospital is in good shape. Health reform experience, if anybody's followed Kansas in the news, it's been pretty checkered. We're in the New York Times weekly for not so good reasons. And so we're still as a state trying to figure out what we want to do when we grow up. And access continues to be an issue. There is zero interest from state government in adopting anything to do with the Affordable Care Act. And so we're trying to navigate how to take care of people in that space. Our governor just announced another 4% decrease or cut in Medicaid reimbursement. So that's affecting folks, especially that have nursing homes. Pros, since the Affordable Care Act has come around, we've increased our access to care. More people are insured through the marketplace, and our outcomes are slowly improving, but we're still trying to figure out what to do with state access. And our incentives are currently still misaligned. We're incentivizing the wrong things. But contrary to what one of our previous presenters said, we have 3 privatized Medicaid MCOs, and all 3 of those MCOs that are managing all the state's Medicaid dollars are expressing interest in piloting something in Kearney County around value-based care and giving us some fund money to really go along with what we're looking at doing or looking at learning from Safety Net Advancement Center. So our learning goals are to identify more informal structures, network structures to leverage new models of care, identifying models of best better practice, and really just learning from our neighbors, learning from folks in New York and Philadelphia and California and elsewhere. We want to learn what you all are doing as well.
All right, thank you so much. Welcome. Next up, we have La Comunidad Hispana. Anyone on the line? I can't hear you if you're on the line, so I'm going to scroll back and if you speak up later, we'll come back to you. I know MPCA is on the line.
Yes, we are here. Thank you. And very glad to be here.
Okay. So
I'll start, Sam. I'm sorry. It's always hard to know when to talk.
You can introduce yourself. I have to pull up your slides are not part of this presentation. My apologies, but you can get started. You can introduce yourself.
No problem. I will. I'm Janice Sherman. I'm the PCA director here in Mississippi, and I have a team of folks here with me as well. And I'll introduce them shortly. But I'll follow the slides based on what we have here. We are the Primary Care Association for the state of Mississippi, but we are really here on behalf of an IPA that was developed by the PCA a couple of years ago, and it's the Primary Care Coalition of Mississippi, IPA. And it's an independent provider association of the 20 out of the 21 community health centers in the state that formed in an effort to create a relationship with an accountable care organization, Collaborative Health Systems. And so that organization has been functioning without a real infrastructure, so the PCA really sort of serves as ad hoc staff and for lack of a better term, in serving the needs of the IPA. And of course, the PCA itself is a membership organization of the same group of individual FQHCs. We have, as our participating group today, 5 individuals, myself included. We have Dr. Sonia Fuqua, who is our Director of Clinical Quality. We have Joseph Grice, who is our Director of Technical Assistance and Training. We have Sandy Munden, who is our CFO. And we have John Lornardini, who's our Director of Communications and Business Development. Some of our people and facilities that are not visual to you there, but across the state, as I mentioned, statewide, there are 21 community health centers, and about 20 of those are actively engaged right now in the activities of an accountable care organization. And part of our reform experience includes the fact that the IPA was formed in 2013. We feel is very positive because it's given us some early experience with different payment methodologies and clinically integrated network. We've also benefited from shared savings in the first round of participation in the IPA or the ACO, and so that's been very beneficial to our community health centers in terms of seeing the value of their work and being able to be incentivized for that. Some of the cons that we are looking at currently have to do with, of course, the lack of an infrastructure for the IPA. We don't currently have a governance structure at all, even though many members of the boards of the Primary Care Association, of the board of the Primary Care Association, are members of the same management committee for the IPA. There's no formal structure. And we're sort of extended as a Primary Care Association staff to provide that support at the present moment until we can really recommend to the board a more adequate structure. And then just the need for a greater level of expertise to maximize our learning, the whole function of the IPA and the success of that endeavor is what we're hoping to achieve and to reverse that con. Our learning goals for just a little bit about our learning goals. We have the network structure. We are looking to assess different levels of infrastructure support to meet the new delivery reform efforts and to build an informed decision-making process for a governance structure, and then to look at options about how we can operationalize the staff for that IPA entity. So thank you very much. We're excited to be a part of the collaborative.
Thank you. New Mexico Hospital Association, preserving access to rural care. Park, is anyone from Park on the line?
Hi, this is Ellen Interlandi from New Mexico Hospital Association.
Thanks, Ellen.
So I'll go ahead. Park was created at our strategic planning meeting last year, and of our 45-member hospitals, we are very much of a rural state. 29 are located in a rural or micropolitan area. Our task force includes a dozen hospital leaders who created the goal and 6 guiding principles, and we support capacity development and goal achievement. This gives us options for creating network infrastructure to support new models of care delivery in the rural areas. The Hospital Association's mission statement, advocating and partnering to support members in improving the health status of New Mexicans. And our Park goal is to create and sustain a viable rural delivery model built upon a culture of trust and collaboration and upheld through visionary leadership. Next slide. So our participation in this project is, we have Beth Landon, who's our project director. I'm the clinical director. We have Brett Goebel, who's our finance director, and several CEOs or senior leaders in 6 of our 5 of our rural hospitals. Christina Campos from Guadalupe County, Sean Lurch, Miners Colfax, Donna Garcia from Presbyterian, Rhonda Maniat from Miners Colfax, and Candace Evans from Miners Colfax. Next slide. So here's some of the participants, just a couple of the pictures we could pull together within 36 hours notice. Next slide. So our health reform experience, we've had some pros and some cons. With regard to Medicaid expansion, 41% of New Mexicans currently enrolled, with estimates of reaching 45% next year. And of course, with the budget shortfall and federal matching requirements, we have had to look at some decisions to cut our Medicaid expansion. Another pro is the quality, greater attention to performance improvements in quality and patient safety. Cons, of course, are varied resources to support those quality improvements. Many of our hospitals do participate in a hospital engagement network, but the small rural hospitals don't have the bandwidth, don't have the software, don't have the capability to collect a lot of data that larger hospitals do have to. So there's a lot of education that has to occur. Again, another pro, alternative payment methods, strong incentives to reform care delivery, so incentives are aligned, especially with regard to population health. And again, as we all know, ACOs, accountable care organizations, and other payment reform models are tricky at best to implement in rural and frontier communities, mostly because of the low volume. So the question, how has health reform benefited our organization? Our member hospitals have benefited very much from Medicaid expansion with decrease in uncompensated care. Next slide. So our learning goals: understand options for network development, understand pros and cons of the different structures, and identify the best model for different programs. We don't know yet what we want to create. Next slide. Okay, that's it for me.
Thank you so much. Is anyone from North Country Healthcare on the line?
Yes, we're here.
Hi.
We're here.
Would you tell us a little bit about North Country and introduce yourself?
Certainly. North Country was founded in the early 90s as a free clinic model and very quickly realized that it wasn't sustainable. So by about 1995, they were granted FQHC status and became a community health center. Between 1995 and 2007, there was significant growth during that time, and 7 additional clinics were added. From 2007 to 2016, we've added an additional 9 clinics. So we currently have 500 employees. We're across northern Arizona, and from our farthest point on the west to our farthest point on the east, it's 576 miles. So that in itself creates challenges for us, with 22 locations spanning in between those 576 miles. We use telemedicine as a delivery for some of our services, specifically behavioral health, into our small, tiny clinics. We're in multiple rural, we're very rural clinics across northern Arizona. The participants for this program are Kim Chen, she's our Director of Pharmacy. Cindy Martin is our Chief Medical Officer. Link Pearson is our Business Office Manager. Amanda Gay is our Director of Outreach and Community Development. I am Marty Neff, I'm the Chief Operations Officer. And finally, April Corona is our Deputy Chief Medical Officer. And everyone's here today except Amanda and April. Kim.
The pros for this is Kimberly Chen. The pros for our organization in approaching healthcare reform were that we've really been advancing in the PCMH model and creating integrated care teams with multiple professions. We have a really robust medical and non-medical programs meeting the patient's needs, not only from a healthcare perspective, but non-medical as well. Another pro to our organization that's helped us to embrace the healthcare reform is that we're actually a multi-learner teaching institution. We have residency programs in pharmacy and dental, and we'll be having a medical residency program starting in 2017. We also take learners from pharmacy, family nurse practitioners, and we have a medical school on site. So the development of these practitioners who embrace rural health care has really helped us to expand our network into that arena. And we really have a strength in leveraging technology to bring services to rural areas, and have been able to be on the front side of CMS and allowing payment models for telehealth appointments. On the con side, as Marty alluded to or spoke to, because of our large geographical area, it poses all sorts of challenges from recruitment and retention of our providers. These communities often have very little to offer in regards to having our providers live happy, productive lives and feel fulfilled in their families. We also have uncertain future in the payment and funding models. That's created some challenges for us. And then also communication amongst our teams, being so geographically diverse, and some of the services being provided via telehealth. It's a constant challenge for us to maintain enthusiasm and communicate so that we provide consistent programming and continue to embrace the same model across all of our networks after we've piloted and found a model that's really effective. To then communicate that across the network has provided challenges as well.
Thank you, Kim. Finally, our goals. Our first goal is the development. This is Marty again. The development of a billing system that transforms to the new payment model, the value-based payment model. Our second goal is operations and clinical integration on the ground floor in each of our clinics, and a system that will support that because we're so far spread. The third goal is the development of clinical teams, and our fourth goal is data reporting. Thank you.
All right. Thank you guys so much. The next, People's Community Clinic. Is anyone from People's Community Clinic online?
Hi, this is Mary McDowell. I'm with People's.
All right. Hi, Mary.
Hello. So we were founded in 1970 in Austin, Texas, in the basement of a local church. Originally, it was a free clinic run by a handful of visionary volunteer doctors and nurses. In the time since then, we've taken many of the steps that similar free clinics have taken. We started accepting payments. We eventually started taking claims-based payments. And in 2012, we became a federally qualified health center. Since 2012, we received Level 3 recognition as a patient-centered medical home. And I am happy to announce that in April, we expanded from an operational footprint of about 22,000 square feet to now about 80,000 square feet. We were able to do a renovation on a big building and started running it, and so far so good. And I'll also add we are still delivering care out of that same church to street-dependent youth living in that area. Our mission is to improve the health of medically underserved Central Texans by providing high-quality, affordable health care with dignity and respect. Next slide, please. Our participating leaders include Regina, our CEO, Dr. Appel, our Chief Medical Officer, Kelly Boland, our Chief Financial Officer, myself, Tony Bernal, our Data Analyst, Alex Berry, Director of Compliance, and Stephanie Parisser, Revenue Cycle Manager. Next slide, please. Our people in our facilities. Yeah, this is a snapshot. We got providers, we got patients, and we are proud to announce we have the prettiest babies of any SQHC. Next slide, please. Our health reform experience, pros, what we put marketplace insurance products in the pros and the cons. On the one hand, though Texas has not gone through Medicaid expansion, the marketplace products did provide a little bit of coverage to folks who didn't otherwise have it, but we have found it difficult to implement on the products just from a contract management and a patient navigation point of view. We have been participating in 1115 waiver projects. That's been very beneficial in terms of emphasizing that focus on outcomes and quality care. But again, no Medicaid expansion in Texas to take the place of those waiver dollars. There's certainly greater interest locally and regionally in aligned incentive structures, but so far there's not a lot of meat on that bone. Enduring confusion around what we mean when we say pay for performance at a local and regional level. And then we're always happy for the support on outreach and enrollment. You know, something I didn't put in here, and I thank the folks who came previously for reminding us, the biggest pro coming out of healthcare reform is emphasis on the patient outcomes and experience. And so what I would add in our goals that I didn't in the beginning, next slide, is that if we can navigate these incentive structures, new contracts, new governance, and still keep our eye on the prize, patient satisfaction and good outcomes. So our learning goals, understanding our organization's readiness to take on alternative payment plans, and creation of a roadmap to close the big gaps in readiness. Getting a better understanding of the local, regional, and informal network readiness. As I'm hearing people talk, I'm already saying, you know, we had focused very much internally and we need to be focusing outward. It's all about the partnership. And then understanding better both our opportunity and risk as we bridge from one incentive structure to another.
Okay, thank you so much. Next we have ProHealth, Rural Health Services. Anyone on the line from ProHealth? Okay. And I know I skipped La Comunidad Hispana. Is anyone on the line from La Comunidad? Okay. With that, we're going to get started with our presentation for today. We wanted to just give you an overview of the full Learning Collaborative times and topics before Amanda and Andy get into our content for today. So this is our first session. We have 6 sessions total. Most are 90 minutes. Our last session, because we'll have group presentations again, will be at the end of August, and it'll be a 2-hour session like this one. And we just really want to express our appreciation to all of you for being willing to share some information and speak up in this first session. Part of what will make this successful in a virtual environment is just the challenge of webinars is that participation can be hard. So we really appreciate all of you stepping up in this very first session and being willing to share more information about your experiences in your organization, because you're going to learn as much from each other as you will from these learning collaboratives. So kudos to all of you. These are our topics. Our next session is on clinical and financial integration. Our third session is about governance and ownership. Session 4 is kind of a case study about Session 4 is about effective and efficient operations. Session 5 is a case study where we'll have a group discussion about building an integrated contracting network. And then our last session will close with hearing from all of you again. So Starling is really excited to get this started. We welcome feedback and participation throughout the Learning Collaborative. We have time to sort of adjust based on your questions, and we'll try and build that feedback loop into our content going forward. So with that, I'm going to hand off to Andy Principe, who will take us through the first half of our discussion today.
Thank you, Samantha. Can you hear me okay?
Yep.
Okay, great. Thank you, folks. It was really great to get a sense of who you folks are. Some of you we actually know in person. Some we look forward to getting to know better over time. But now we're going to shift gears a little bit and start some of the formal education that will make up the remainder of today's virtual learning collaborative session. I'm going to take you folks through some content around the value of clinical networks, really focused on why groups such as yourself are feeling some desire and in some cases some pressure to get involved in formal network activities. And then Amanda is going to take you through some really kind of grounding education in the types of clinical networks that we're seeing emerge throughout the country in response to some of the trends that I'll talk about. We've left some time at the end for group discussion. We want you folks to be able to ask us questions, make comments, even ask each other questions, if that makes sense. So we'll move through this content and make sure to provide you folks with an opportunity to comment and question as we go. So why do networks matter? And I can certainly tell you from Starling's experience, the number of organizations, safety net organizations throughout the country who have this very question on their mind is significant and seems as if it's growing. And that's largely because in many cases, as states in particular are starting to take action under various health reform type approaches, whether they be 1115 waivers, whether they be expansion of Medicaid programs, there is some natural pull towards growing our scale as it relates to the overall healthcare economic landscape. As we shift from volume-based to value-based payments, we feel that safety net providers will essentially be put under increasing pressure to operate more efficiently and develop the ability to measure and communicate the value of the care that they provide to payer partners. And provider networks provide both the infrastructure and the economies of scale necessary to achieve these goals. What we mean by this is that value-based care, in essence, requires us to demonstrate on a much more granular basis that the care that we provide in the communities that we serve is having certain benefits on those populations of patients. And we typically talk about the triple aim. Patient care, patient experience, and cost of care are really the three cornerstones of how we evaluate and measure value of all healthcare providers. But safety net providers, given their legacy of being involved typically in a broad spectrum of the care of the people that they serve, are feeling this pressure very specifically. Provider networks are emerging because many safety net providers are not sufficiently large to be of immediate value-based contracting interest of the payers that operate in their region. Even if that's the state Medicaid agency directly, oftentimes we find that safety net providers, some of them serving many Medicaid patients, but still may not be enough to enter into unique financial relationships regarding those patients. I want to talk a little bit about the shifting landscape that we see health reform applying essentially to the world in which we operate. And of course, the first is the payment for volume to payment for value shift. And we hope that none of you on the phone are in any way offended by our assessment, as you see on the right here, in which we've identified some areas where we think safety net providers are extraordinarily well positioned, some areas where we feel they are moderately well positioned, and then other areas where we feel there's some significant work to do to be as well positioned as possible to address these changes. And part of the reason why we've assessed safety net providers nationally as being moderately well prepared for payment for value is first and foremost the holistic approach they take to providing care to their patients. But also, we feel as if safety net providers are well positioned in the primary areas of interest. Most of what the Affordable Care Act and other health reform initiatives has done or focused on is in fact the safety net population, because that's seen as the biggest opportunity, if you will, to fundamentally change the cost of care, quality of care profile that was one of the financial underpinnings of both the Affordable Care Act and most other federal, state, and local health reform initiatives. However, we don't feel that all safety net providers are well positioned because we have traditionally operated under payment methodologies that tend to feel generally pretty safe. And we can talk a little bit about those, and we know that that's going to be an area of exploration as we go through this initiative. And shifting from volume to value causes us to rethink whether we're ready, or think about whether we're ready to participate in something that might feel fundamentally less safe. As we talk about the pre-reform environment, we know that there is a significant amount of care that's provided in facilities, typically hospitals, but certainly other facilities as well. And there is generally a desire to shift, whenever possible, care to the community setting. And safety net providers have really taken a leading position in this regard, identifying ambulatory sensitive conditions, working closely with their patients on whole health needs, and forming partnerships, as you heard with some of the presentations this morning, with primary care capacity through whatever means necessary to really change and shift the way in which people are able to experience the care that they need. So we feel this is an area of strength for the safety net. Now, that may not feel like that for everyone on the call, and particularly some of our facility-based groups might be feeling a pinch around this in a different way. But this is one of those things that we hope to address with you as we talk about how networks might, fundamentally change the financial realities of health reform for your organization. We heard some of you mention or comment on the role of the health insurance marketplace, and the Affordable Care Act brought with it an opportunity for folks who did not qualify for either employer-sponsored health care or government-provided health insurance to seek affordable individual insurance options through the health insurance marketplaces. And some of your states may have seen a much greater penetration of that than others. We feel that the safety net is reasonably well positioned to address this. On the one hand, one of the downside of many of these plans has been that the plans do tend to carry with them very high deductibles, and oftentimes patients are unaware that even though they may now carry insurance, that they still may be responsible for a large percentage of their healthcare costs. But on the upside, we've got a great tradition of working with patients at all levels of ability to pay for care, and so have some very significant tools at our disposal to kind of maximize the value of those relationships. Another downside, however, and one that networks attempts to address, is with the low penetration of patients into these plans, we individually might not be able to secure contracts that are any more interesting or valuable than very low or often Medicaid fee schedule-based payments. And thus, networks give us some ability to work with payers on the marketplace to develop unique relationships. In the pre-reform environment, there was little data on quality, cost, and outcomes. And people often ask us, what is the fundamental difference between this attempt at health reform and attempts in the past, often referred to as the managed care era? And in our experience and in our perspective, it is the very fact that we have built to a large extent the infrastructure necessary to collect data on a variety of different data elements, such as EHR data for quality measurement and claims data for cost evaluation, that should fundamentally change our ability to study costs in context with access or restriction of services. But this is an area we have some concerns for the safety net. Even though in many cases safety net providers have led the way in terms of implementing electronic health records, they have often lagged behind their commercial or private healthcare competitors or partners in working specifically with data sets beyond typical QI data sets. Very few safety net providers that we've worked with have even had access to claims data, let alone have robust tools for managing that data to a specific outcome. Pre-reform, much of the payment system was designed around rigid workforce and scope of practice models, and although that has not changed dramatically, we're seeing some softening of that. And what that means is that individual safety net providers or networks of safety providers can now begin to rely on processes like care coordination and community health workers to essentially work through the types of barriers to health and wellness that traditionally would only be paid for under direct fee-for-service reimbursement and would require certain licensure. We'll talk about how these networks might adopt certain capabilities and now have the ability to be paid for that don't always require a certain level of licensure typically associated with MDs, DOs, PAs, and NPs, and the like. Historically, we've relied exclusively on physicians as the source of medical decision-making. This is changing. We have the ability to utilize tools like EHR and other clinical decision support tools to really embed evidence-based guidelines into our care, and then often utilize non-physician resources to execute on the plan. It's often referred to as doing what's right for the patient because we know it to be true, such as testing a diabetic for an A1C if they haven't had that tested in a certain period of time. And even though, again, we feel safety net providers have been somewhat pioneers of utilizing these tools, when we refer specifically to networks, what we have yet to see is kind of network level or broad-based level agreement on evidence-based guidelines that really impact the triple aim. Historically, care was provided in solos. There was a high burden on human resources to coordinate care. We still don't see enough organizations that get data on when their patients have been admitted to the hospital or seen in an emergency department. But it is improving. This is the health information exchange aspect of health reform. And so we think safety net providers are generally well positioned here, and in many cases are kind of taking the reins or leading certain initiatives about improving transitions of care, but there's still much work to be done. I'll close this slide by saying the historical pre-reform environment was very much focused on the process. We bill for certain steps that are taken in delivering care to the patient. And in a post-reform world, new payment methodologies do allow us to be much more focused on the holistic needs of the patient, which we think has nothing but upside for our stakeholders, for our providers, and for our organization if we can embrace those concepts. I want to take a very non-political look at the overall influence or the macro level influence on health reform and talk a little bit about why it's really driven us to look closely at forming and joining networks in order to be as effective as possible under health reform. The overarching goal of the Affordable Care Act and most other health reform initiatives is to identify non-value-based healthcare financial resources and turn those into insurance pools. This includes cost and encounter-based payments, DISH payments, uncompensated care pools, and patient responsibility. Now, I want to make sure it's clear, I'm not saying these aren't valuable financial resources or valuable services that are being provided to patients. They don't meet the definition of value-based. And the definition of value-based is that the payment is tied to a specific patient and tied to the outcomes achieved by the patient as the result of their care. All of these types of financial resources are typically paid on a volume basis. If we provide a certain number of encounters, we might receive a certain percentage of a DISH allocation. Insurance pools were the great compromise of the Affordable Care Act. And ultimately, that led to an increase in what we refer to as private managed care enterprises, essentially organizations who take financial risk based on the amount of money in those insurance pools for providing a broad set of the services necessary to keep patients well. This has led in virtually every market throughout the country in increases in 3 areas. And it varies in terms of what percentage of the insurance resources are flowing into these types of entities. But we have traditional managed care. In the Medicaid market, this would be our Medicaid managed care organizations. And in many states, these have been the predominant place where these financial resources are being placed. In other, in all states, some of those financial resources are flowing into marketplace plans, creating, in some cases, wholly new insurance companies that we now have to learn how to interact with. And in other states, and in many states, it has led to a rise of what we refer to as provider organized managed care, where providers themselves are taking direct accountability for those financial resources without an insurance company intermediary. And this has created a set of 3 very hot topics in the safety net world. Management service organizations, or MSOs, which are organizations that allow our safety net providers to tap into centralized services that help them interact with traditional managed care, marketplace plans, and provider organized managed care. And Amanda, in a few minutes, is going to take you through much more formal definitions of each of these 3 concepts. We have independent practice associations, and we know they are well represented on this phone call, which are contracting entities that are designed to take advantage of the scale of multiple independent providers and use that scale to contract for the best value-based terms possible with any of the 3 types of private managed care enterprise. And accountable care organizations, or ACOs, which interact typically directly with governmental payers, although sometimes with commercial and Medicaid managed care payers, and sign unique relationships whereby they have distinct incentives to maximize the triple aim for the patients that they serve. And much of this virtual learning collaborative session and the rest of our sessions under this virtual learning collaborative will be focused through the lenses of these 3 types of organizations. In terms of some of the important health reform trends that each of you has probably experienced in your local community, we encourage you as safety net providers to really keep track of what's going on in your environment. You've probably all experienced, and in some cases have experienced, a very dramatic shift in your payer mix. If you've seen Medicaid expansion, you've likely seen a decrease in the uninsured population. You've seen patients move into marketplace plans that didn't exist before, and which fundamentally changes the financial relationship you need to have both with them and with their insurance company. Some of you may have already accepted or are working with your state or with your payers on new reimbursement models. And we know that this is a trend that's likely to continue. The very challenges associated with operationalizing the triple aim is probably something you're dealing with already. We heard some of you talk about the increased need for data and the type of information that's going to allow us to better manage patients, not only when they're in our buildings, but when they're in their homes and when they're traversing the rest of the healthcare system. We also need to look at ways of engaging patients and beneficiaries in new ways. We heard folks talk about telehealth or telemedicine as an opportunity to engage with patients when they aren't physically located close to the settings for care. But we also need to be effective at getting patients to seek care, not when it's already at the point where they may not be, where we may not be able to get them back into control, but where they've already experienced a negative outcome. How can we get a population that may have historically not had insurance or the financial resources to seek care to do so even before their situation becomes so severe that we have very limited ability essentially to work with them. We also operate in an environment where we expect increased competition for our patients. This will be much more pronounced in urban markets. I know we have a lot of rural-based groups with us, but we also think that rural-based groups need to be aware that others are seeing now a financial opportunity for serving our patients. And so while we may feel more secure than our urban peers, we have to understand that new business models and new technologies are allowing people to come into our marketplace, even if we've historically thought of our marketplace as hard to serve because of its rural or pioneer frontier nature. And lastly, and the primary focus of our discussion throughout this collaborative, is providers organizing under new network models. And this isn't limited to safety net providers. Perhaps there's an ACO already operating in your community. Perhaps you've seen hospitals and health systems aggressively recruiting primary care as direct employees. And perhaps you've seen an emergence of new non-safety net networks that are increasingly expanding their access to patients as they join marketplace plans or become eligible for Medicaid. All of these have an impact on us. And what we've typically said to folks is that our state will probably drive the most significant percentage of this change. But how our peers and how our competitors operate in our local markets also have a significant impact. Before I turn it over to Amanda to get into the details of the various network models, I want to talk briefly about a model that we use to describe the value that we provide. And every single payer, whether it's a Medicaid managed care organization, whether it's an ACO, you sign a participation agreement, or whether it's your state Medicaid agency, is looking for a formula for evaluating the value that your organization provides. And obviously, this is not the type of equation we can plug numbers into, but we want to talk about the relative importance of different aspects of the care we deliver and the impact that it has on our value. As we increase as we increase quality, we increase our value. If we could provide care that manifested itself as better scores against important quality indicators, we will, in essence, be perceived as more valuable by our payer partners. However, if we do that at the expense of increasing the total cost of that patient's care, then we may not, in fact, increase our value. If cost goes up and quality stays the same, our value actually declines. And that's why we've represented them in an inverse relationship. Not quite that simple, however, because there are other elements to consider. The next is risk. And when we look at the quality we can achieve and the total cost of care necessary to produce that quality, sometimes safety net providers don't look as good as we should. But often that's because that data has not been adjusted for the risk of the underlying population. To understand risk, you simply need to ask the question, what would the outcomes of this population been if not for the care my organization provided? And oftentimes, this allows us to start to think about ways of describing our quality and associated costs for the complex population of patients that safety net providers typically serve. And lastly, none of this matters if we don't have sufficient scale to add the additional patients who need to seek primary care as they become increasingly insured, because without seeking primary care, they run the risk of being a significant burden on the system. We need to get them into ambulatory settings so that we can maximize, essentially, the opportunity to keep them healthy. If you remember math class, multiplication by 0 equals 0. So we might be the highest quality, lowest cost provider and manage a really risky population to good outcomes, but the payers that we interact with are going to ask us to do that for 1 more patient, or 10 more patients, or in some cases, 10,000 more patients. And our value in terms of being able to get into relationships, financial relationships with those payers that align with value-based purchasing often comes down to how many more patients we can run through our processes, place in under care in our organizations, essentially in panel to our providers, and still deliver that level of care. With that, I'm going to turn it to Amanda, who's now going to take you through a discussion of the three major types of clinical networks.
Thanks, Andy. And I guess I want to stop for a second and just kind of get some reaction from the group before we move forward and I start wowing you with a bunch of information about networks you're probably already considering. I want to go back for just a quick second, and I want to just kind of get a gut reaction from our cohort here about some of the trends that you think are most impactful for you right now, and what is really in the forefront of your mind when you start thinking about how working together with other providers might support some of your strategic goals. Andy did a great job of talking through on slide 42 about all the various trends that we're seeing. I'd love to hear from folks about where you guys feel you're feeling the most pressure to respond. This is the participation portion of today's Learning Collaborative, so we would love to hear from folks. And if you're not careful, I'll just start calling on you.
Sam? Is it Amanda? Oh, Amanda. Okay, Amanda, I'm sorry. Amanda, this is Jana Sherman in Mississippi. I think clearly the most pressure is really in the collaboration and networking with other providers, non-traditional providers, like mental health and home health and skilled nursing facilities, because that's what's being put on the table from the ACO model that we're involved in. And FQHCs are really, they're sort of this ominous thing surrounding the conversation that doesn't really move very far when we have those deliberations. So I think that's an area that we are definitely feeling pressure for, because I know it's a part of the future and not quite sure how we're going to move along and kick that ball down the road.
Yeah, I think that's an excellent observation. And I would be really curious to hear from the folks over at Cincy Smile, since you guys are almost entirely, if not entirely, oral health providers. I'd love to hear from you as you start thinking about the types of reorganization of your internal structures and some of the things you're thinking about. From the dental health perspective, what some of your experiences or challenges or successes have been as you've tried to think about really expanding those partnerships with non-traditional partners.
Yeah, so we've had a lot. I mean, being in oral health, it's always difficult to partner with different medical facilities, especially because dental health is so different from medical health. It does become difficult to kind of coordinate with other providers. I do know that we do partner with a lot of other nonprofit organizations to ensure that we are providing oral health, but that doesn't necessarily mean that we're communicating with their medical providers. So engaging and kind of networking and partnering with non-traditional providers is definitely very difficult for us.
Thank you. And I think many folks are facing those challenges. Anyone else on the line, have you identified other trends that, because I think this issue of trying to organize across provider types is probably something that we would add to the slide in the future, because I definitely hear what you guys are both saying in this, and it's one of those areas that it's easy to talk about when you're submitting an ACO application or trying to put together some kind of collaborative effort with payers, but it's a lot harder to do in practice. So I think that's a great one to add. Does anybody else have any other trends that they're seeing that are really putting pressure on you as you think about reform activities?
Hi,
this is
Ellen.
Jason.
Oh.
Go ahead, Ellen. Ladies first.
Thank you. I guess I would add the rural ability to document and prove quality outcomes. And this would be from the acute care perspective. We have found that because many of our hospitals are not required to submit quality outcomes because they're critical access hospitals or they don't participate in the Flex grant, they have no idea how to measure and analyze quality outcomes and make differences in their care based on that. They still collect some of the old process things, did you get your aspirin, blah, 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 but no outcomes. And I think that is a handicap when they go to look at trying to say, yes, we do deliver quality care.
I think the whole issue of performance management, effective use of data, data-driven decision making, I think those issues are just paramount in some of the not only systems change that needs to take place, but workflow changes and accountability shifts that are going on. If anybody's ever heard any of those of us from Starling talk, you will often hear me repeat this ad nauseum, but in our view, data really has become the currency of healthcare reform, and being able to not only access and utilize and analyze your own existing data sets is going to be more important going forward, but using new types of data, whether that's patient engagement data, whether that's claims data, these are all new competencies that all of the safety net is struggling with and really provide a great opportunity for providers to work together in a networks construct to help support that. Because if we learned nothing else from electronic medical record implementation, I think the lesson we learned is how expensive, both in terms of time and resources, those types of endeavors can be, and really thinking about how do we measure our performance, how do we use data in new ways, and how can we work together to create economies of scale around that is critical. All right, we had one other comment. Oh, go ahead, sorry.
I was going to say, as Donald Berwick from the IHI used to say, in God we trust, all others must bring data.
Exactly. We had one other comment before I kind of shift us into some, thinking about how we address some of these concepts of networks. Who did we cut off there? Was that James? I didn't hear who was.
Jason.
Yep.
Jason with Flip on. And actually, two comments. One, I want to go a little bit deeper on the integration with other types of organizations. We're finding it's one thing to develop the relationships. We've been successful with some. The greater difficulty of working with other types of organizations, particularly in chemical dependency and behavioral health, is the integration of systems to allow data flow. Most EMRs, in our experience, the ones we've talked with folks about, are not properly configured to handle chemical dependency information. And certainly our RIO is not currently configured that way. So we think one of the big challenges is going to be ironing all the kinks out of the infrastructure so data flow, and to the point you were just making, data is king. So data flow does feed everyone the information they need to really get into population management. The other point, and I alluded to it when we opened up the comments earlier, is that there is a terrible shortage of primary care and behavioral health practitioners. In addition to competition for patients, we've got competition for staff. We're already starting to see escalation in salaries. So there is going to be a cost impact, unintended, no doubt, but there will be a cost impact due to that shortage.
Yeah, that's absolutely true, and we're definitely seeing a trend where if it weren't already hard enough to recruit safety net providers, into some of the organizations that you work in because of either perceptions about the population that you serve or the sort of demographic and geographic challenges that you have, the need for providers to help provide the access, to the patients that are necessary under these new models, it's just becoming fierce. And I think a lot of the traditional models of recruiting, And this also begs the question of, do we really have providers working at the top of their license, and are we utilizing, well-oiled, highly efficient care teams? There are a lot of issues that impact this issue of our capacity to stay staffed up. And I think that's definitely a good point, and I think we really agree with that. So great. So what I want you to do as we're progressing, really through all of our discussions, feel free to raise your hand, interrupt, throw something in chat. We've got all three Starlings on the line right now. So if I'm talking and miss something, I know that Samantha or Andy or Kaylee from the Advancement Center will notify me. I'm going to spend a little bit of time now talking about the types of clinical networks that we have seen really emerge as models for how providers work together to try to face some of these challenges under reform. And I want to just sort of make a point that, while we're talking about very formal, legal structured networks, for those of you that aren't quite at that point, I think a lot of the principles of why we want to work together in collaboration with other providers hold true, whether we're talking about formal entities or not. So more than anything, I want to punctuate a point that Andy made early in the discussion around the piece about, really looking at how you can work together to sort of efficiently work to address some of these options. Oh, it looks like, do we have a raised hand here? Oh, Seema, do you have a question or a comment? I'm sorry, I missed your earlier raising of the hand.
No, I was just wanting to say that the total cost of care or providing care for example, we do provide HIV/AIDS care, patient care, and that seems to be on the higher end of the risk if we are to join an IPA or an ACO that is determined as a risk. So how do we work with independent practice associations to look at that differently?
Right, and I think that's an excellent point because, some of what our experience has been is some of the most complex and highest cost patient populations have really been the center point of a lot of reform pilot activities. And what you see is that some of the more traditional models of sort of care management need to essentially be put on steroids in order to really support these patients and create the kind of care transitions and care coordination that are going to be most effective with them. So we can make sure, as we're talking through examples over the next several weeks, Seema, that we try to punctuate some of the examples that we're providing with real life experiences that have dealt with that, and that is a concern. But I think we'll talk a little bit about sort of the what risk stratification means when you start to look at some of these types of payment and care delivery models, and I think it's an important point to raise.
Right.
So, and from our perspective and what we've seen really is that healthcare providers across the spectrum of what we call the healthcare ecosystem are really looking to engage with some very specific patient populations. And I think the one that Seema identified is a great example of that. More and more, there is an emphasis on providers really working together to learn and establish new best practice around managing the cost and quality legs of the triple aim, and that in so many ways, the safety net providers represent pioneers in these areas. If nothing else, just because you've had to be scrappy in the past with the amount of resources that you've had. But fundamentally, one of the values that we really believe that safety net providers bring to the table is that you really understand the value of partnership, and it's inherent in so many of your missions. And you play a really important role in providing that nexus between the patient and the rest of the community that they live and work in. And we think that's critical. Of course, safety net providers have probably a better sense the non-safety net providers about the social determinants of health. You've witnessed for many, over the years, how important those social determinants are in the eventualities of their health outcomes, and have really helped to build a safety net around those patients that go beyond the provision of dental services, mental health, primary care, tertiary care that you're providing. And then finally, and I think I didn't write down who said this, but I thought it was such a great point during the introduction that one of the upsides of what's happened with reform has really been the increasing emphasis on patient engagement, activation, and choice, and that we're seeing more and more that that patients play an increasingly important role in not only the development of these new care models, but also in the delivery of care and the overall management and evaluation of these systems. As Andy indicated, typically what we see is that there are 3 different types of networks that have emerged in order for providers in the safety net to engage not only with payers, but also to engage in their ability to prepare for new models of care delivery and reimbursement. We like to split these out because we see a lot more similarities than we do differences, and it's also important, I think, to understand that the deeper we get in this work, the more we realize that these 3 models actually can work interchangeably with each other. We think that's important because as you start to think about formal entities and formal arrangements to tackle these care delivery and reimbursement changes, you might want to be thinking about incremental steps for developing them. And certainly there are several folks on the phone already that we know that are, may represent a certain network construct, but might be partnering with others. And so it's important to just think about how the 3 models work together. Managed service organizations typically are organizations where groups of providers come together to create economies of scale in particular areas of operational, clinical, or financial efficiency. What we see this really is about optimizing efficiency and effectiveness, and managed service organizations will typically look at how can we share services, and this ranges broadly. This could be anything from provider credentialing to revenue cycle management to health information technology, and anything on down the line that's really going to assist health centers and rural hospitals and safety net providers in creating some shared services that are going to create efficiency. Typically when you see MSOs emerge, it's because there are some new, capabilities or capacities that providers need to shore up on or implement, and they haven't typically had the experience to do that individually. So you see groups coming together in order to do that. This begins from our perspective, this is probably the lowest risk in terms of really bringing providers together around some of these areas, because the cost and the trade-off is really around building the new capacity and implementing that. Contrast that then to independent practice associations and accountable care organizations whose focus is to work with specific payers in order to manage the care and the cost and quality outcomes of those designated patient populations. Under the IPA and the ACO models, and truthfully, there's not a lot of difference in terms of structure with these 2 models. The participation and the program requirements might vary based on the contract, and the patients might be more specifically defined, for example, under an ACO. But structurally, the idea that you have an entity that is engaging on behalf of a group of providers to contractually engage with the payer to manage those cost and quality outcomes, conceptually, it's not that different. The IPA and the ACO model hinge on the group of providers working together in a clinically integrated manner, essentially proving that by working together, they are more effective and more efficient at meeting those cost and quality goals for the patient populations that they serve, and that they are agreeing to and adhering to a shared set of performance measures. Some of those will be designated in the contracts themselves, and others may be identified by the network specifically to optimize the value proposition that those networks are making in the broader environment. IPAs have the flexibility to work with as many payers as they deem appropriate. Again, where ACOs typically look at specific payer opportunities, whether it's a Medicaid ACO demonstration program in your state or region, or a group of providers coming together under the Medicare Shared Savings Program. Any question? Now, one of the things to understand is that we've seen a lot of networks pivot. You know, they started out maybe as an MSO and then transitioned to an IPA once they had a little bit more focus on their strategies around payer engagement. Or you might have IPAs and ACOs that are essentially, operating within the same entity. So we've seen a lot of groups that started out in the Medicare Shared Savings Program as an ACO, but over time really saw how the infrastructure of that ACO could be leveraged to bring value to other payers. So they, have pivoted their contracting capacity to look at other types of payer contracts. IPAs and ACOs always will need infrastructure that often can either be built internally or can be leveraged through some other contractual relationships with existing managed service organizations. So these three types of organizations all have a correlative relationship to each other, and often there's a high degree of compatibility in the goals, objectives, and infrastructure. Any questions on this before I move on? Okay. So I'm going to spend just a minute defining a little bit more detail about what each of these organizations are. We like to use the Medicare Shared Savings definition when we talk about accountable care organizations. It's typically the model that most safety net providers are most familiar with. But again, principally, the foundational pieces of the Medicare ACO are what we see many states that are implementing Medicaid ACOs. They're really looking to the Medicare program to give them, a lot of the cues and signals about how to structure this. So Andy talked earlier about basically provider-led strategies for managing those non-value-based payments. And ACOs are just that. They are groups of doctors, hospitals, and other providers who come together in a voluntary way to give coordinated, high-quality care to the patients that they serve. The linchpin of the ACO model really is the care coordination model, and particularly as it relates to compromised and chronically ill patients, being able to better coordinate that care across the provider types that patient is interacting with. When ACOs are successful, they create a savings over baseline costs in previous years, and it's those savings then that are distributed across the participating members of the ACO. Independent practice associations are a little different. These are individual organizations that participate in a centralized contracting entity. The individual members maintain their independence and autonomy and board and governance requirements, but they're able to work together to create economies of scale in the market with payers so that their influence and their ability to secure more favorable contracting terms is enhanced by that scale. To some degree, it might be a requirement that there need to be shared business and clinical infrastructure They're likely to be required to adhere to certain clinical and other standards, largely tied to whatever the contractual requirements are of the payers. But this really allows groups to come together to create consistency in the marketplace and to really support their ability to test out new models of care and payment delivery, but do that in a way that there is some shared dispersed risk, so that it's really the Independent Practice Association that holds the financial risk versus that risk being wholly absorbed by the individual practice. Any questions? Okay, and then finally, I talked about this already, but the managed service organization really is that entity that provides that shared infrastructure for any number of different services, sort of back office, front office, clinical, or the like. Okay, so when we talk about this, we try to sort of show kind of what the structure and the models are and how this interacts with models that you might be contemplating or models that you might be providing in. What we have here as an example is a horizontal network of providers. This is actually a real model. It's an independent practice association of federally qualified health centers. What you see here is that they have created a horizontal model. It's a dual model. It's the ACO-IPA model. The providers at the bottom represent the participants in that. And their ACO has created a core set of centralized services to really maximize the efficiency and increase the value proposition of the network with payers. They focus in three areas: clinical performance, operational excellence, and financial performance. And by doing so effectively, has really been able to change the dialogue and the discussion with the payers that are operating in their market. Another model is the idea of a more vertically integrated model. Some of you might be working with, for example, Medicare shared savings programs that are integrated with health systems or hospitals. And what you have here is that you have that sort of vertical model of providers working together to help support that particular patient population, and that might include community health centers, specialty groups, independent practice associates, independent primary care providers, working in partnership with the health centers. And so a lot of times what we see here is, a coordination coming together, where safety net providers are then pulled together through these hospital-centric models. Typically what will happen in that situation is the safety net providers are really identified as the resource for the most acute and complicated patients, but really working through that vertical system to help support those patients. Both models, whether they're vertical or horizontal, neither one is better or worse, but they're just different ways of organizing around those systems. I'd love, though, to kind of open up a discussion here and have a little bit of, get some feedback from you on sort of what you guys see as some of the opportunities and challenges of working in either of these two networks. We know from our experience, and we can certainly prime the pump, but we would love to hear from you guys about what you think the pros and cons of working with providers in a horizontal network versus a vertical network might elicit in terms of your thinking. And I know there are some folks who are in horizontal networks that are on the line, so it would be good to get a sense of why you had identified horizontal networks versus vertical networks as an option. Jason from Flippa, any thoughts on that? How about the folks from Mississippi?
We're certainly horizontal, and we've just started to have conversations around possibly vertically integrating, and I mentioned some of those challenges earlier. So, I mean, the pros are, that there's, consistent identifiers and, strong relationships, and, we're able to look at data sets that are common across the system. The cons are that we're able to do the same thing. It's only our data, and it's not integrated in terms of looking at across a vertical network. So that's a huge challenge.
Yeah, I think that's definitely something that we've experienced as well. I think there's a lot of concern. I think there's a sense that there's more. You're potentially giving too much away if you enter a vertical network in terms of overall governance and oversight of the network. Making sure that that all providers and the constituencies that they represent are adequately represented in the governance and oversight process is critical. And sometimes it's hard for folks who aren't the centralizing organization in a vertical model to feel like they have that kind of influence. And as you indicated, horizontal networks tend to be more inclusive because you already speak the same language, you're already working together, you understand the strengths and limitation of your care delivery model, but making sure that stays integrated with the community at large and the other providers your patients are going to interact with is critical. Seema, did you have another point or question?
No, I was about to say that the governance structure would change in a vertical model, and the structure to bring about changes may be more, it would involve other entities and may be much more difficult. And in the horizontal model, I think the infrastructure and the data integration piece and implementing that at a large scale versus a vertical model already may have that infrastructure that we could align with.
Right. Do you guys have a sense in terms of these two models? Do you have any idea about what you think from your experience or just any preconceived notions you might have around which of these models you think is likely to provide higher quality care?
More so horizontal, if we are able to get the infrastructure in place and have the data integrated and all the effective interfaces working to make that happen.
Yeah, I mean, I think again, I don't know if there's any right or wrong to this one. I think, a lot of it may depend on how the entities are set up or structured. But I think that, we've definitely seen a shifting in the thinking in terms of used to be that these, highly, health system centric models were going to be the most effective. And that's not always really been the case in what the, research has really shown to bear over the last couple of years. Smaller horizontal led networks can be just effective, if not more effective, because they have less administrative burden that they're trying to account for. But there are a lot of opportunities to really look at the strengths and the attributes of both models. Any other thoughts before we kind of move on to the next piece? So we wanted to, this is a little bit, this skews a little heavy on the community health center side, but what we wanted to do was sort of give you an indication of what the trends are in terms of national networks of safety net providers. And the National Association of Community Health Centers put together a survey last year where they, asked community health centers and primary care associations around the country, where are there emerging models and how is that taking shape as it relates to reform trends in those states? And we see more and more that this idea of implementing provider-led models of care and provider-led models of centralized efficiency are really starting to emerge. And so this is just the old red, yellow, and green model, but you start to see that, in fairly short order, the significant trend is really going to be toward, moving in this direction. I highly suspect in other segments of the safety net, just based on the work that we've done with critical access hospitals and some of the other partners, that we're going to see this move more and more in that direction as well. So really just to kind of give you guys a sense that you're in good company. You're not necessarily the first set of folks to be thinking about this. There's a lot of good research and experience out there, and to what extent possible we can share and support all of us as we're on this journey. We just want to let you know that there is a lot of movement in that way. As I mentioned, these network models are not mutually exclusive. We see many times that groups have created these sort of incremental stepwise approaches. Let's start with some shared services and build over time to a more complex relationship with each other around, the accountability of shared contracting with payers. MSOs can provide a really important set of services back to IPAs and ACOs, or don't have to do that. They can operate separately. It might be, for example, from the work that you're thinking about tackling, that maybe shared services won't have anything to do with these contracting networks, and that's fine. What we want to sort of just suggest is that as you're thinking about developing or engaging with these networks, you're thinking through what some of the longer term implications might be of looking at a more incremental approach. But if it turns out that there's a very specific set of services that have emerged as critical for you to tackle some of the reform challenges that you have, and it lives in a separate entity, and it just focuses on that, that's fine too. It's important to think about these things are not, your efforts and the activities that are going on in your environment are not going to be happening in a vacuum. There are going to be lots of opportunities for networks to really play a role in assisting providers in developing some of the core competencies that they're going to need to really take the challenge of value-based reimbursement and the challenge of new care delivery models to the next step. Some provider-led organizations are really going to be in the driver's seat in terms of leading the conversations around system redesign and reimbursement redesign in the communities. But others, may be forced to be a little bit more reactive to what's going on and look at creating these models from more of a self-preservation or a defensive posture. Other groups are going to identify and contemplate the value of working within health systems and those more vertically integrated models. Again, so many of those decisions and those variables are going to be predicated on existing natural relationships that you have in your community. Many safety net providers have found, or just as an example, have found a lot of value in partnering with their health system partners around things like EHR and more specifically health information exchange. So there might be some very good reasons why you look to do that. In any case, whether you look to drive the conversation yourself or work in partnership with those more vertically integrated models, networks are going to be a centralized component to really help develop those core competencies and think about how to create economies of scale and really create some shared and leveraged resources in order to be able to be effective. Here's what we know. And Andy did a good job of talking about this earlier when he talks about the value that effective networks bring to the marketplace. Payment change is truly driving new organizational models, different payment options, and we're going to talk about this, in sort of later stages of our discussion with you guys, but different payment options have different performance requirements. And we talked a little bit, even in today's call, about how critical being able to measure outcomes and use our data, and being able to effectively use our data is in the grand scheme of things. And it's important that we think about how we're organized in order to meet those reporting and data challenges. The tools and skills and infrastructure that we're going to need in order to really engage are going to vary, but there are some common themes, and we can really look to see how care is being centralized. Some of the best practices around care management and data use and patient engagement really are promulgated across these various strategies. And regardless of whether you're working with a Blue Shield Medicaid managed care grant or a contract under the MSSP or a pilot project in your state, those core principles are the same. And so what we always want to encourage folks to continue to think about is, if I'm building a certain type of infrastructure and a certain set of competencies for this particular initiative, how does this affect and impact our ability to leverage so that we can really take that to scale when we look at our broader strategies around engagement on reform activities. And finally, we think there are a lot of options for safety net providers, although we do see the environment starting to shift a little bit more in the direction of trying to move folks more quickly down the pathway of some of the more complex models of value-based reimbursement. But there still are models to really available to you to test this out in a safe way, so that you can start to work together. You can implement some of these approaches and activities before you have to roll it out to every single patient in your patient population. Pilot projects, opportunities to look at specific patient populations or look at specific geographies, we think are important first steps to be taking. And just based on the conversation that we had with you guys this morning, it's clear from the way that you guys are approaching the projects that are part of the Advancement Center that you're already starting to think that way. And we really want to take those opportunities, investigate them with you over the next, several weeks, and talk about how we can really expand those learnings, not only within your own organizations and your regional partnerships, but really with the group that's gathered here. And, we'll just say this because this is what we see. We really think gone are the days where a strategy for dealing with what's going on with health reform in your area that involves putting our heads in the sand and wishing it would just go away. That's really diminishing. We're seeing more and more pressure come from CMS and from states that are really going to ask safety net providers to step up to the plate and not only participate in these types of initiatives, but really be leaders in them. Okay, so Sam, I think I'll stop there, see if anybody has any questions, and then turn it back to you.
Sure. So we have about 5 minutes left, and Kaylee at the end of this will link to an evaluation survey that includes a couple of questions, just general evaluation questions, and then the questions that are up on the screen here. And we have a little bit of time to sort of discuss this as a group. If you guys have any other questions about the presentation or comments, this is the time to do that. But kind of going forward, we'll ask questions like this, discussion questions, at the end of each presentation. If we have time to discuss like we do now, we'll do that. But we'll also ask you via the evaluation to complete them, and then we'll share that data back with you at the beginning of the next session so that you can kind of get a picture of the different experiences and the content-specific experiences that you have within this cohort. So we just wanted to set that context, and we do have 5 minutes if you want to answer any of these over the phone or via chat right now. We can do that now. I'm curious, maybe for this third one, any of you, the benefits you've experienced or you're expecting to experience, maybe those of you who are in the process of forming a new type of clinical network or joining, sort of what the thinking was to, if you have any more thoughts on sort of your motivations to enter into that arrangement.
Samantha?
Yes, ma'am.
Hi, it's Mississippi. You know, we are involved, as I mentioned earlier, in ACO and have formed an IPA. And I think part of the biggest benefit is really just the power of the data that we've been able to look at in terms of, you know, hospital admissions and how our centers really compare across the region and across the country, and being able to really take that data to frame the context for having a seat at the table. And it's really in a, you know, just mild stages right now, but even at its very, you know, infant stages, it's really a powerful tool. So that's certainly, you know, I think a great benefit that we've experienced.
This is Seema with Present Care. What we've observed is we're part of a IPA, and they provide us with data, but when we compare the data to what we have in the system, close to 400-something clients are not actually have ever been patients in our system, but they've assigned it to us. So it's like this constant back and forth, trying to understand where they're getting the data from and what's the truth source for that data.
That's really interesting, Seema. And I know, I mean, that's I've spent some time both in the provider setting and on a health plan side, and so the IPA is the bridge between those two. And attribution is a huge issue with ACO and MSSP development, but sort of patient assignment is and how to effectively work with providers and make sure that if you're from a health plan perspective, that your patient, you know where they're going, that they have access to care. That's a huge problem for insurers as well. So the fact that you're starting to delve into that data and try and figure out, you know, where your information is disparate from what your IPA or health plan has, that's the first step to really showing how much value you can provide to a payer. Where are you in those conversations? And have you found anything useful and useful strategies in figuring out sort of where the root of the discrepancy between who you know your patients are versus who the IPA has assigned to you?
We definitely know who our patients are. We've separated that from the patients that were attributed to us. Now we need to move forward with a discussion with that team to see what their attribution model has been, and whether we're looking data differently or they are assigning it to us differently. Don't know where it'll go, but it's just starting.
Thank you.
And we would actually, and I want to just piggyback on something around this, and Andy can pipe up too. Well, you know, we would basically just let you guys know that challenge around who you think your patients are and who's been attributed to you is really one of the central challenges of some of these new models. Being able to effectively identify where those gaps are in terms of who those patients are and how you can work to effectively activate or engage those patients that weren't previously on your radar there's a high value both to you as a provider, to the payer who's really seeking to make sure that those patients are properly managed, and frankly to the patients themselves. We think this is a really critical competency, and one that often is best supported and coordinated through some centralized services. And I know Andy could probably speak for hours about, you know, some of the financial upsides and downsides of these challenges.
I'll just make a quick comment because I know that we're up on time, but one of the, I think, benefits, really kind of undisputed benefits of value-based payment systems is that it does have the ability to change the conversation from, you know, this person's on my roster, but I don't know who they are, to this person's on my roster, had extraordinarily high costs last year that could be greatly benefited by the care model that I've put in place. Because of their high costs last year, I have a financial incentive to identify them, find where they are, and then bring them into my care. And in doing so, and look, this isn't all about money, we know that, but in doing so, I stand to be not just financially sustainable, but actually, essentially increase my margin because I've got a shared savings opportunity or I'm under a capitation model. And just to maybe get a little too philosophical, I think that's possibly one of the best ways that safety net providers can really not expand their mission, but expand upon their ability to deliver on their mission, is to now have the resources potentially to impact people in our community in that way. So that's certainly something where we balance. We help the organizations we work with balance. Is of course you have to be able to reach these patients, and that's not always possible. But when they are potentially reachable, even if they haven't been seen in their care, it's not as if they're coming to us without the resources, the financial resources necessary for us to do something impactful for their outcomes.
All right, and with that, thank you all so much for participating and for having great questions and being active participants in this first session. Kaylee included the link in the chat box to the evaluation. We appreciate and welcome your feedback. And I'll hand it back to ASU in case there's any closing information that they'd like to share. But just we appreciate all of your time, and we're looking forward to the rest of the sessions with you.